I'm Tamara Thomas, editor-in-chief of UrbanHealthToday.com, part of the DocWire family of medical news sites, and I want to thank you for tuning in to Urban Health Weekly. Our goal each week is to keep you informed of the latest in health and medical news right from today's headlines. It's time to empower yourself with open conversations about your medical care with news that matters to you. So are you ready? Let's get started. This is Urban Health Today, and I'm speaking with Dr. Andrew Hertler, an oncologist and CMO of Evolent. He's here to talk about the updated pancreatic cancer screening guidelines that include individuals carrying the BRCA1 and BRCA2 gene mutations. Thank you for talking with me today, Dr. Hertler.
Thank you. It's my pleasure to be here.
It's really great to have you here. Let's get started. Can you give a high-level overview of the pancreatic cancer prevalence among those with BRCA1 and 2 mutations?
Certainly. I think first of all, we need to speak a little bit about pancreatic cancer in general. The overall risk for the population, lifetime risk of developing pancreatic cancer is about 1%. That would be considered the average risk. If you have a BRCA1 or BRCA2 mutation, that is increased. More so with a BRCA2 than BRCA1, probably somewhere between a 5 to 10% lifetime risk if you have BRCA2. BRCA1, we're a little less certain. It's probably in the range of 5% or a little less. If you look at what these percentages equate to in terms of increased risk, for BRCA2, it's probably a 3.3 to 10-fold increase in risk, and probably about a 2 to 3-fold increased risk for BRCA1. So they clearly increase the risk, though I would point out that there are a lot of other mutations that can lead to pancreatic cancer as well.
Such as?
Examples would be a genetic mutation in a gene called CDKN2A. There's something called Peutz-Jeghers syndrome. There's Lynch syndrome, which leads to colorectal cancer. It can have uterine cancer, but also has pancreatic cancer. And then there are a number of genes that cause hereditary pancreatitis, which is recurrent inflammation of the pancreas, but those patients also have an increased risk of pancreatic cancer. And then there are also patients who have come from families that simply have a dramatically increased risk of pancreatic cancer, but we can't find a specific genetic mutation. But certainly those are people who need to be screened as well.
Wow. Could you provide an overview of the new pancreatic cancer screening guidelines and what prompted these changes?
Certainly. These were issued by the American Gastroenterological Association back in 2020. And their first piece of advice was that screening should be considered in patients who are at high risk. Well, who's at high risk? Well, patients with these mutations, as well as first-degree relatives of patients with pancreatic cancer, if you have at least 2 relatives who have pancreatic cancer. So I had alluded previously to people with a family history without a genetic mutation. So realizing that the large majority of pancreatic cancer is sporadic, somewhere between 85 and 90%, don't have a family history, don't have a genetic mutation. They are not recommending screening for these individuals. Rather, they are recommending screening for those patients who carry some of these genetic mutations, including the BRCA1 and BRCA2, or for patients the family history of pancreatic cancer.
And how do these differ from the previous guidelines?
Well, the previous guidelines came from the USPSTF, and they quite simply recommended against screening for pancreatic cancer in asymptomatic individuals. So essentially, there was not a recommendation for screening. whereas the American Gastroenterological Association is recommending for screening for those patients who fall into a high risk group. And generally speaking, what do we consider high risk? Well, someone who has a lifetime risk of 5% or higher, be it from family history or one of these mutations.
So is it that they've looked back at BRCA2, they've looked back at pancreatic cancer patients and discovered that they had BRCA2 mutation?
That can be, that's one piece of it. The large majority of families that are identified with BRCA mutations actually are identified through one individual in that family who had breast cancer or ovarian cancer, which are the most common malignancies that develop in patients with BRCA mutations. Once these patients are identified, generally speaking, the rest of the family, the first degree relatives, that being brothers, sisters, mother, father, children, are offered testing as well. And if they test positive, they are recorded in databases. So over the last 10 to 20 years, we've developed quite a database of people who carry BRCA mutations, and these individuals have been followed, and we have been able to determine who develops cancer with these mutations and how often do they develop it. So that has contributed a great deal to our understanding of which malignancies patients who carry these mutations are at risk for.
And so how do these new guidelines improve early detection of pancreatic cancer?
That was one of the things that I think is very notable about this screening. There have been some studies done that look at how often do they find cancers in these screenings, and are they early stage or not? I.e., in other words, are they very early, have not spread to the lymph nodes, have not spread elsewhere, or even what we call precancer lesions? That these are changes within the pancreas which indicate they're highly likely to turn into pancreatic cancer, but are not yet cancer. One that's we commonly refer to is called intraductal papillary mucinous neoplasms. They're not really yet a full-blown cancer, but if identified, they can be removed, and the patient will, in all likelihood, be cured. But in looking at the studies of screening of high-risk individuals, they're finding that either cancer or one of these precursor lesions are found in just under 2% of patients. That may sound low, but that's much higher than what you would expect just screening an average population. And when they took these patients to surgery, early stage cancers, what we call stage 1A, or these precursor lesions, were found in about 2/3 of the cases. That is very important because while overall we don't cure many pancreatic cancers, if one looks at all comers and who's alive 5 years down the road, sadly, it's only about 4%. However, if you look at these precursor lesions and stage 1A cancer, which is what they're identifying on the screening, those patients do have a very good chance of surviving long term. Not only that, but over the last decade, we've seen an improvement in survival of these early stage pancreatic cancers. In fact, from 2004 to 2012, we saw that 5-year survival almost double, from 45% to 84%. So the screening does identify cancers and changes that will almost certainly develop into cancer in patients. And two, what we're finding is not finding an incurable disease. We're finding patients who might actually have a pretty reasonable chance of being cured, which is why this is also very important.
Hmm. So, what are the main challenges in pancreatic cancer screening, and how do the new guidelines address them? Well, actually, if I could backtrack for 1 second, what does the screening entail? What is the screening?
The recommendations of the AGA, the American Gastroenterologic Association, was to combine two different modalities for screening. Endoscopic ultrasound, this is when very similar to when you do a colonoscopy, but
Mhm.
the endoscope is inserted down the esophagus into the stomach and as an ultrasound probe. And you can then ultrasound the pancreas directly through the intestinal wall and get very good views of it. I had mentioned how difficult in some of our previous discussions it is to image
Right.
and to find pancreatic cancer. And
Mhm.
to combine this with an MRI for high-risk individuals, suggested this be done annually. If you see something that is mildly suspicious, but you weren't sure, you would probably do it again in 6 to 12 months. If you saw something that was intermediate in suspicion, you might do it in 3 to 6 months. Um, and if it was a higher suspicion, you might go as short as 3 months. But it's an aggressive screening protocol.
Yeah, sounds very similar to breast cancer screening, where the window shrinks as the
Yes, yes.
probability. What are the main challenges in pancreatic cancer screening, and how do the new guidelines address them?
The major challenge is getting patients to centers that are experienced in pancreatic cancer. The guidelines actually suggest referral to a pancreatic center of excellence for patients who are undergoing screening. What I would add to that is there are not that many of those centers. And in many cases, particularly to socially disadvantaged groups, access to those centers may be difficult. They could be 100 miles away, they could be 200 miles away. So this can pose a big challenge. So I would say that at the very least, patients should be seen at a center with a significant volume of pancreatic surgery. In other words, that will imply that they have experienced surgeons and experienced gastroenterologists who are doing the screening. So I believe access is a major challenge. Another is just familiarity with the guidelines, realizing that it's largely primary care physicians who are going to institute and recommend screening, and how aware they are. I'm not certain all of them really have this top of mind. They think about
Right.
prostate cancer screening, they think about breast cancer screening, but do they think of pancreatic screening? I don't think they generally do.
And in your opinion, why is there a knowledge gap about the risk of pancreatic cancer?
Um, I think it's probably multiple different reasons. When primary care physicians have a lot of screening that they're responsible for, they've got not only cancer screening, but screening for high cholesterol, hypertension, diabetes, making certain that people get their mammograms and pap smears. There are a lot of things that they need to remember. And I believe that for this reason, a malignancy such as pancreatic cancer isn't the one that pops to mind. That being said, pancreatic cancer is the fourth leading cause of cancer death. So I think that's probably something most people are not aware of. I think a second reason might be that uh, I just quoted some data about how early stage pancreatic cancer has a very significant cure rate, but overall results are still dismal for pancreatic cancer. And I believe that
Yeah.
many primary care physicians have believed that it is not worth screening for something that will, in their minds, almost certainly be fatal. So those are two reasons I believe that this just doesn't pop to the forefront.
Hmm. I wonder if endocrinologists who tend to see, the diabetic patients, I wonder if they would benefit from some sort of education or sort of collaboration with oncologists. So, for example, if you're treating a diabetic patient, you have to make them aware that diabetic retinopathy or DME, diabetic macular edema, could be in their future. So you would, as an endocrinologist, you would refer this patient out to see an eye doctor. I wonder if the same could be done because if you've got high insulin levels, then your risk of pancreatic cancer is increased, correct?
Yeah, in fact, one of the presenting scenarios of pancreatic cancer is presenting with diabetes, a sudden onset of diabetes is something you don't infrequently see. The difficulty is, of course, those patients, you'd like to diagnose them even earlier than before they develop diabetes, but it certainly can be something that pushes one to think about pancreatic cancer. And I think endocrinologists would be more likely, far more likely to pick up on that, realizing that the large majority of diabetics are not being seen by endocrinologists.
So how does collaboration with other medical specialists play a role in screening and treatment of pancreatic cancer?
The most important collaboration is going to be with the primary care physicians. You want to diagnose people early, which means they're probably asymptomatic. And what we're looking for is patients who carry one of these mutations or who have a dramatic family history. Now, for a primary care physician to remember the list of the different mutations that can be precursors of pancreatic cancer, that's probably not a reasonable concern. But what is very important is to get that family history of cancers and to identify patients who come from a family with an increased history or may carry a genetic mutation. And that screening has to be not only for pancreatic cancer, an example would be in BRCA for the BRCA1 and BRCA2. So we think about breast and ovarian cancer, they cause many other cancers as well. Pancreatic cancer is one.
Right.
There can be an increased incidence of prostate cancer. So you need to take a family history of all the malignancies. And when you see a family that is just having a large number of cancers identified, one, you need to be very aggressive with your screening, but two, you probably want to get them out for genetic testing and genetic counseling. So it's got to be, in my mind, the primary care physicians who are those that we most need to reach out to. Now, certainly a second group would be gastroenterologists because they're seeing a lot of patients with largely they're going to see patients for colonoscopies and gastroscopies, but they're going to identify patients with cancers. And this also should promote looking for that family history to try to identify these families that are increased risk. So those would be key groups in my mind.
But Dr. Hertler, if you're identifying the people with the cancer, isn't it almost too late at that point if you're seeing large amounts of cancer? You kind of want to get them before that.
Yeah, for pancreatic cancer, that's certainly true. However, if you it may be too late for that individual, but it may not be too late for their brothers, their sister, their children, because these genes are inherited. So yes, for the individual patient you've just diagnosed with pancreatic cancer, if you haven't been detected on screening, your chances of surviving that pancreatic cancer are very low. However, if we can identify that this is a family that has multiple people with pancreatic cancer, or if you find a BRCA1 or BRCA2 mutation, then you can test all of the other family members for that mutation. And though you may not be able to save that initial patient, you can institute screening for all those other family members and may be able to dramatically benefit them. So it's still very important.
I have the BRCA2 mutation. And at my last visit to my primary care physician, he mentioned it to me. He's like, by the way, you've got to start thinking about, and I've had my colonoscopy, but he said, you've got to start thinking about pancreatic cancer screening, which.
Good for him. Good for him.
Yeah.
Because he's right. You would fall into that group that would benefit from pancreatic cancer screening. So kudos to your primary care physician. You've got a good one.
But I had the unfortunate benefit of losing my mother to breast cancer, to metastatic, breast cancer. And that led to my genetic testing. Well, actually, my mother died of breast cancer, my grandfather of prostate cancer, and so that qualified me for the testing. And then that opened the door for, this summer I had the prophylactic mastectomy, and that led to my doctor talking to me about pancreatic cancer screening. But most patients don't have the benefit of having that happen in that order. So my life is saved, but I guess I'm just trying to figure it out.
No, I would. I know you didn't ask me a question, but I would agree completely. I'm a huge believer in checklists and a very detailed family cancer history at your annual physical exam, or when you have care started with the primary care physician, is very, very important because it can identify patients who should be see a genetic counselor, have genetic testing, and be screened for cancers. So having a checklist and having that part or initial visit with a primary care physician, couldn't agree more. Very, very important.
So in your experience, what's the most important thing for both patients and doctors to understand about pancreatic cancer screening?
I think one, we're still not advocating it across the board for all patients. We're advocating it for patients who are at increased risk of pancreatic cancer. So that would be the first piece to understand. And I think a second is that one needs to always discuss with a patient, and there are pros and cons to anything. Now, I'm a huge advocate of screening because I firmly believe that the only way we're ultimately going to beat cancer is by diagnosing patients earlier.
Absolutely.
That being said, patients need to understand that when they undergo screening, that if they fall out with something suspicious, this very well could lead to biopsies and surgical procedures and additional medical procedures. Now, I think that in the appropriate hands at centers experienced in the treating of these conditions, those risks are minimal, but at the same time, in decision-making, patients need to be made fully aware of that.
What future research or developments do you foresee in the area of pancreatic cancer screening?
That's an exciting area, and I say that because one thing we haven't mentioned is endoscopic ultrasound is not a minimal procedure. You're going to be sedated in all likelihood. You're going to have a scope put down your throat with a probe on the end of it. And you're going to have an MRI as well. Many patients do not if you have any kind of claustrophobia or if you've ever been in an MRI.
Yes.
I've been in them a number of times myself, and it doesn't bother me at all, but I've had many patients who literally cannot tolerate it. So this is not necessarily simple screening,
Right.
but there is a lot of very interesting work going on, which I think is very important, not just for pancreatic cancer, but for all cancers, looking for what we call biomarkers in the blood, in pancreatic fluid and cyst fluid, that could make it far easier to screen patients. And these could be something we know that, for instance, tumors have mutations within their DNA. This DNA circulates in the bloodstream, and people are working on tests that could potentially find markers, indicators that they might have not just pancreatic cancer, but multiple other cancers with something as simple as a blood draw. Are these ready for prime time yet? No, unfortunately, they are not. But I am cautiously optimistic that not just for pancreatic cancer, but for all cancers, we are going to see dramatic changes in screening and the ability to screen with simple blood tests rather than putting people through procedures. And that will be a game changer in terms of diagnosing and screening for cancer, because it will make it much simpler, much less invasive to the patient, and actually much less costly.
Would a blood test pick up a precancerous lesion, for example?
It could, and one of the concerns about these tests, and some of them are actually in existence, but if you find the marker that the patient's at increased risk, what percentage of patients are actually going to develop cancer? Or there'll be a percentage that may have the mutation or the circulating DNA or the protein or the biomarker in the blood, but they're never going to develop cancer. So what percentage do develop cancer? And then let's say you find a biomarker, you put them through screening. Let's say you have some kind of a blood test that you say that says you're at risk of pancreatic cancer. Are they going to be depressed? Are they going to be anxious because you found a blood test that says you're at increased risk of this cancer, but then you screen them and you can't find anything? And you're going to continue to screen them. So those are some of the issues that we need to be cognizant of. All of that being said, I believe this is going to be the future. How soon, I don't know, but that's clearly the direction people are looking.
I think another challenge is going to be getting insurance plans to pay for this from a patient's perspective. That's, and probably a clinician's perspective as well. That's probably going to be a source of frustration. Coverage may not include, they may say it's not medically necessary. We don't see where it's warranted. That may be an issue as well.
It may be an issue, but it's a subject I talk to payers frequently about. And my point is always, one, all of these genetic tests are dramatically decreasing in price. If you go back in the 20, 25 years when we first sequenced the human genome, that was a project that cost millions of dollars. You can now do this genetic screening for $2,000 to $4,000. That may sound like a lot of money. That being said, when you look at the cost of treating cancer, where the drugs that we use to treat and advance cancer are easily $20,000 to $30,000 a month. My point to payers is not encouraging this screening, this genetic testing is, in my mind, penny wise and pound foolish. That you can save dramatic money by screening. And I say, don't worry about the testing, because we can use testing to screen. We can also use it to help determine what the appropriate drugs to use for an individual patient are. Well, the most expensive therapy of all is going to be the one that doesn't work. So get the testing, get the right medications to the patient. You will save money, and stop worrying about the cost of the test and worry about the cost of taking care of advanced cancer.
Dr. Andrew Hertler, CMO of Evolent, thank you again for your time today. Thank you for this knowledge. Really appreciate
Thank you for having me. It's been fun.
Thanks for listening to Urban Health Weekly today. I hope you'll join me and my friends next week so you can stay informed and inspired to take control of your health. See you next time.